Thank you for your invitation. It is a real honor to be here today. Today I will speak about the role of body composition assessment in the HCC management. As you know, the prevalence of obesity has increased dramatically in the last 50 years. And I will try to... And if in 1975 we had in the men prevalence of obesity was 3.2%, now in 2014 it was a report that showed that it is the other way around. Sorry, it is 3.2, and in 1975 was 0.8. While in the women in 1975, the prevalence of obesity was 6.4%, while yet now in the women is 14.9%. Moreover, the obesity, the morbid obesity has a high prevalence, more in women, and is 1.6%. We all know that obesity is associated with an increased risk of the occurrence of the tumors. But several authors found a paradox, and this was that some patients that were obese apparently had a better outcome comparing with patients that were non-obese. Moreover, patients assessed to immunotherapy, obese patients, had a better response to PD-1, PD-L1 blockade. And it was published by Brown and meta-analysis where included 11,724 patients with cancer. And he showed that in the patients with leukemia, with colon carcinoma, melanoma, lymphoma, renal tumors, patients who had a higher BMI had a better overall survival. But let's see what happens with the patients, with the cirrhotic patients. In 2011, Berzigotti found that the proportion of patients with compensated cirrhosis who had a clinical decompensation had a higher body mass index, independent of the portal pressure or the liver function. And what about the HCC patients? Premorbid obesity was associated in a meta-analysis with 2 times higher risk of HCC-related mortality. And this association was more pronounced in men and Western population. But do we really talk about an obesity paradox, or in fact we speak about an BMI paradox? We use in the clinical praxis the body mass index, but we know that, you can see here, we can have 2 patients with the same BMI, but in fact one to be only muscles and the other one to be only fat. On another limit of the BMI is that it cannot quantify the liquids. So in cirrhotic patients, in fact, after the water was subtracted from the BMI, they observed that in fact 11–20% of the patients had a very low body mass index. And here you can see very well, it is a patient with the same BMI. And in this case, we have more muscles. Here we have more visceral fat. So why it is so important to evaluate BMI, besides that the body mass composition, besides the fact that we will know much more accurate the nutritional status of the patient. Adipose tissue produce adiponectin that are involved in lipid metabolism, insulin sensitivity, and hepatic steatosis, and in fibrogenosis. While muscle is the main site for the ammonia detoxification when the liver function is impaired. So we have a patient that is sarcopenic, and he has high levels of ammonia, but on the other side, hyperammonemia stimulates the myostatin, and this stimulates the autophagy, and it's inducing and worsening of the sarcopenia. Which methods do we have to assess the body mass composition? We have the CT MRI, DEXA, and BIA. But for the patients, in the case of the patients, cirrhotic patients, for us, it would be much more easier to use CT or MRI assessment. In 2004, Shen showed that a single abdominal cross-sectional CT image at the L3 can provide an accurate estimation of the whole body skeletal muscles and the adipose tissue. And how we do this, we take an image at L3, and with a special software called Slice-O-Matic, based on the density of the different tissue, we can know that it is a skeletal muscles, it's a visceral adipose tissue, or subcutaneous adipose tissue. Moreover, we can have information concerning the quality of each tissue. And we have for sarcopenia different cutoffs, because it is a difference between the Asian and Caucasian population. Myosteatosis is known as the low skeletal muscle radiodensity on the CT image. This means that in the muscles, we have a high quantity of fat, and sarcopenic obesity is sarcopenia in an obese patient. Sarcopenia is the most well-known in the cirrhotic patients, and to conclude that a patient is sarcopenic, we need information about the muscle mass, the muscle function, and the muscle strength. As I told you, sarcopenia is well known in this common finding in the patients with cirrhosis, not only due to the impaired liver function, but also due to the catabolic state, due to the hyperammonemia. And to all these, we add in HCC patients factors that are related to the tumor. And what do we know about sarcopenic patients with hepatocellular carcinoma? It was a study published in this year. Was a meta-analysis where included 57 studies, and they showed that the prevalence the prevalence of sarcopenia was 41.7% in patients with hepatocellular carcinoma, and the patients who had sarcopenia had a higher rate of mortality, had a higher chance to have a recurrence of the HCC after it was treated, and the rate of response was between 0 and 45.5% in the sarcopenic group, while in the non-sarcopenic group was between 12.7, 66.7. And also the sarcopenic patients had a higher rates and or risk to have side effects. What about the systemic therapy? Several studies published in the last years show that it's an independent predictor for the low overall survival, complications, side effects, and this is valid also for those treated with TKA or immunotherapy. But let's look beneath the type of iceberg, because we talk about sarcopenia, about obesity. Let's see what is happening in fact. In patients with normal muscles and without excess of adiposity, we have a high amount of interleukin-15 and adiponectin interleukin-10. Interleukin-15 produce an increased antitumoral activity, stimulates, in fact, the natural killer lesion, natural killer cells, and this is associated with increased response to immunotherapy. We have sarcopenic patients and sarcopenic obese patients, sorry. In these patients, we have a pro-inflammatory milieu with high levels of IL-6, TGF-beta, TNF-alpha, interferon gamma, and low of PD-L1. And in this combination of changing, we'll have senescent lymphocytes T that don't have enough PD-1 receptors, and we have a low response to immunotherapy. Why? In the patients with obesity, depending by leptin, we'll have lymphocytes T, we call exhaustated lymphocytes T, that have an upregulation of PD-1. What is and I found very interesting about this exhaustated lymphocytes T is that during the immunotherapy, they can pass in the phase of senescent lymphocytes T and to have a low response. So the patient can have at the beginning a high response, and after that to pass in a low response. What about the abnormalities in the adipose distribution? You know that the adipose tissue is formed from subcutaneous adipose tissue and visceral adipose tissue. When we assess the body mass composition, I told you that we evaluate the volume of the subcutaneous and visceral tissue, but we can check also the density. The subcutaneous adipose tissue provides energy in hypercatabolic states, and this is very important for the oncological patients. They need energy in this hypercatabolic state. This I will show you later a bit the results. And the visceral adipose tissue is associated with increased expression of pro-inflammatory cytokines and reduce quantity of the anti-inflammatory cytokine, which is associated with natural killer immunosenescence. On the other side, it's increasing IGF-1, insulin levels, increase the autophagy, promotes the HepG2 cells survival, and increase risk of the metastasis. And why the density of the adipose tissue is important, which information it brings this? And a high density is associated with the remodeling and with the morphological feature of atrophy. This means that the adipocytes are small and chronic inflammation, or it shows that it's an accentuated process of fat browning with the result of overexpression of VEGF, what you know that is associated with high risk of recurrence of metastasis. And now let's look in the results. There are several studies done in the HCC and the authors looked at the subcutaneous adipose tissue. And what they saw that the patients with high set volume is associated with a better survival in HCC patients with TACE. On the other side, the rapid depletion of subcutaneous fat mass and muscle mass is associated with the poor prognosis. And here we conducted a study where we included two cohorts, this one from Switzerland and from Newcastle. And we looked at the quality of the fat, the subcutaneous fat, and we found that high fat density correlates negatively with overall survival in the HCC patients. What about visceral adipose tissue? This is considered the bad fat. High quantity of adipose tissue was an independent factor for HCC in male patients with cirrhosis and the risk factor for recurrence. High density of visceral adipose tissue was associated with 2 higher times risk for mortality compared with their counterpart. But what the BCLC tell us about the nutritional in these patients? I looked and I found only one sentence. In clinical practice, the evaluation of a patient's status incorporates BCLC staging and simultaneous the expert and personalized approach in the treating physician multidisciplinary tumor board who consider the tumor extension nutritional status. So I think that we if we want to do like a tailored therapy, we should look much more deeply in and to take into account much more the body mass composition. Because it's not enough to say that the patient is obese or not. We should see and evaluate which is the body composition and which is the quality of muscles or of fat. So in conclusion, nutritional status, we agree all that plays an important role in the outcome of HCC patients. And body mass composition assessment can offer additional information concerning the nutritional status. And maybe in the future, a better understanding of body mass composition maybe will allow us to shape the body composition towards the most responsive ones. Thank you very much for your attention. And
thank you, Pompilia.
Questions?
I see that Professor Amadori has a question.
Oh, yeah, sorry.
Yeah, this again is a very important topic. Maybe we all don't know that obese people may be hypoproteinemic. So you may look at the protein in the blood, and it may be hypoalbuminemic. So again, we have to say that the liver really like a lot proteins. And most of the, the largest part of the liver is made of proteins. So maybe one has to take this parameter also into the consideration and see, malnutrition may mean, eat a lot of carbohydrate and fat, but not enough proteins. And this may lead again to tumor development. So this is a big issue. It was very important. What I just missed at this point, I mean, how is the deficit in proteins in the serum?
I think that we have a big problem because when we check in this patient, by cirrhotic patient, we look only in albumin. We check only the albumin. And to be honest, I think it's not enough because we know that to increase albumin takes time, and we have patients that we give high proteic nutrition, and despite this, they remain with the albumin low. So I think that maybe when we evaluate the nutritional status, we should check much more. And really, I believe that albumin or prealbumin is not enough.
Can I make a comment on the albumin? Colombo speaking.
Yeah.
I've been very much impressed by the talks delivered by Mauro Bernardi and others in the past 2 years or so. And they taught us that, an accurate control of the albumin metabolism in patients with cirrhosis plays an important role in terms of prognosis. What they really state is that you need not only to look at the serum levels or the circulating levels of albumin, but you have also to change completely the circulating albumin through infusion of fresh human albumin, because this has in return a great benefit in terms not only of opsonic activity, but also in terms of immunity, in terms of improving the general equilibrium of the metabolic status of our patient with cirrhosis. Of course, granted, patients with cirrhosis who are sarcopenic have a more dismal prognosis with respect to the rest, but albumin needs to be refreshed and changed through intravenous infusion. For instance, there is a recent trend in using intravenous infusions of albumin to prevent and treat encephalopathy in patients with cirrhosis. It's something that we have started learning in the very last 2 or 3 years. Can you comment on this, please?
I know that it was a study done in UK. It was a multicentric study, and the conclusion was, I know that in Italy you use albumin. The conclusion was that they didn't change the survival of the cirrhotic patient after infusion with albumin, and also they didn't decrease the numbers of the episodes of encephalopathy. So the conclusion of the study was that is no benefit of giving albumin. And what I can say, and we ask at that moment that with all of this, you give albumin? Yes, we give albumin. So, but the conclusion of the study was negative.
Right, I'm aware of it, but also I'm aware of the argument that has been raised between the two groups of scientists, because the study is different in terms of modality and the quantity of albumin infusion. So I think that it's still open, and I think we need more studies.
Yeah, you're right. I mean, if I may just say, the level of albumin you try to reach as a goal in these patients is also a matter of discussion. And there is one point, which is, I think, the elephant in the room, is the quality of the albumin you give. The albumin can be, there's SH group, you can have disulfide bound. The quality of the albumin you provide to this patient is also quite important. It's more difficult to know, but there is a beautiful paper, Rajiv, on that several years ago in hepatology. So it's a very interesting topic. Yes. Professor Amadori.
Yeah, no, I just want to, support what Massimo Colombo said. I mean, you just don't need to change albumin, you need to give albumin, it just improves everything, circulation and so on. So it has been done 1948, it has been repeated 1962, 63, by Losowski, and Losowski did the best studies. Well, it told you what is the level of albumin you need in the serum, to avoid to get ascites, and it's everything has been done. You don't need to repeat every time the same thing. I think the story is clear. Okay, you need to have a normal serum of albumin, and then you can address all the topics you want. But unless you don't have it, all the publication, there was one recent paper, New England Journal of Medicine, just throws to the trash can. This can be thrown to the trash can. This is not science. When you put the normal limit at 3 grams of deciliter, it's not enough. You need to go above 3.5. And then you can study whatever you want, but you need to have a normal albumin serum. So albumin saves lives, and not only in cirrhotic patients.
I totally agree. I'm pro albumin and pro giving to the patient. I would want to ask you if do you have experience, for example, are patients where you try to increase the level of albumin, you improve the nutrition, and the patients remain with the same level of albumin despite improving the nutrition. Are you aware that below a certain quantity level of the albumin, we should give albumin to increase the level of the albumin, and only after that to continue with the nutrition, with the improving nutrition? I don't know if I was clear enough.
You know, you would observe wonder, you know. That's what did the people in 1948, you know, the Americans, and it was Losowski saw, but Sherlock didn't like it because albumin at that time was very expensive. You know, most of the people were alcoholics, so they maybe thought it was not worth to do that. But there's no doubt. Give albumin, go to 4, and then study and observe the patient. They will not go into encephalopathy. They will not get ascites, and they will, you know, possibly increase their muscle mass. So, I mean, this is experience.
Yeah,
you don't need to invent the warm water.
Yeah, now currently I think the cost is a barrier to the correct use of albumin in the vast majority of hospitals, for instance, in Italy. And I predict that with arrival of engineered albumin, we will completely change our attitude, and we will have a better understanding of how it's valuable to fix the right albumin levels in the body of patient beyond the cirrhotic domain, you know, post-traumatic, post-burnings, whatever. Is dramatically useful.
Right, exactly.